Welcome back to AMC Decoded. This is our high yield MCQ series, part number 7. Before we dive into this tricky case, I have a quick question for you. If you want a dedicated video series on learning basic and high yield ECGs specifically for board examination, drop a comment below or send me a message. If there is enough interest, I'll make a full series on it. Now, let's break down a classic cardiology case that loves to trap students on the exam. It looks like a simple indigestion, but the ECG tells a deadly story. Let's get started. A 58-year-old male presents to emergency department complaining of epigastric burning and nausea that started 2 hours ago. He denies classic crushing chest pain but admits to feeling heavy in the chest. He has a history of hypertension and smoking. On vital examination, blood pressure is 98/60. Heart rate is 54. Oxygen sat is 96% on room air. A 12-lead ECG is immediately performed. Based on the ECG findings and the patient's presentation, which of the following medication is contraindicated as the first-line intervention? Now, I want you to pause the video right now and lock in your answers. If you said nitroglycerin, then you are absolutely right. Now, let's try to decode it. First, look at the ECG. We see significant ST elevation in leads 2, lead 3, and lead AVF. We also see reciprocal depression in leads 1 and lead AVL. This is a classic acute inferior wall myocardial infarction. The inferior wall is usually supplied by the right coronary artery. Now, here is the trap. Up to 40% of inferior MI also involve the right ventricle. Why does this matter? A failing right ventricle is extremely preload dependent. It needs high volume to pump blood into the pulmonary circulation. Nitrates, like nitroglycerin, are potent vasodilators. They drop preload massively. If you give this patient nitroglycerin, you cut off the fuel to the right ventricle. His venous rhythm drops, cardiac output crashes, and he develops a profound, life-threatening hypotension. To make sure you never miss this on examinations, let's quickly visualize the leads. Leads 1, AVL, V5, and V6 in blue are the lateral leads. Leads 2, 3, and AVF in the red are your inferior leads. Leads V3, V4, V1, and V2 are anteroseptal leads. On the actual ECG grade, always check for reciprocity. If you see elevations in inferior leads like lead 2, lead 3, and lead AVF, look up at the leads 1 and AVL. If they are depressed, that confirms your diagnosis. So, if nitroglycerin is out, how do we manage this patient? We use the mnemonic Monabash. Immediate therapy. For immediate therapy, we give aspirin 300 mg chewed, and a P2 White-Will inhibitor like clopidogrel or ticagrelor. Start unfractionated heparin or enoxaparin. Now, we don't use nitroglycerin for our patient as our patient had inferior MI. The gold standard is primary PCI within 90 minutes. For long-term management, beta blockers, ACE inhibitors, statins, and heparin only used during acute phase. Eventually, we will start with beta blocker, ACE inhibitor, and statins to stabilize the plaque and prevent remodeling. Let's bring it back to the question one last time. Why did the patient have a heart rate of 54? Because the right coronary artery often supplies the AC node and AV node, which increases the vagal tone. Why was his blood pressure 98/60? Because his right ventricle was already struggling to maintain cardiac output. Recognizing these subtle clues, bradycardia, hypotension, and inferior wall ST elevation is how you save the patient and how you pass the exam. That's it for today's case. If you found this video helpful, hit that like button and subscribe to AMC Decoded for more high-yield AMC content. I'll see you in the next video.